So I want to welcome others coming on. I'm seeing Bagman. Bagman, are you able to hear me? Hello? Bagman? To look some
Hello.
people. Hello?
Hello, I hear you.
Yes, you hear me. You're welcome. You're from? Where are you based?
I'm based in Kinshasa.
Oh, yes.
Yeah.
You're welcome. You're welcome. We are happy to have you. Actually, I've been following up. We have not yet received the names of the people who are coming for the October meeting from DRC. So
Okay. Yeah.
I hope after this call, we will have to finalize that. I've been talking to Nadine, but we'll finalize after that. We need 5 people from DRC to join the meeting that is going to happen in Kampala in October 15th to 17th. So it is now our time to start. So the other people will find us on course. So I take the pleasure to welcome all of us. We have about 15 hubs on. Where I'm based, I have about 10 people in the room. They may not be able to introduce themselves, but this is the Ugandan hub. And there are quite a number of other hubs out there. But just use the chat box and let us know how many you are at your sites. Then I want to take the pleasure to welcome our presenters. We have a very interesting presentation today about demand creation. And we have a subject matter expert by the names of Solange Baptiste from International Preparedness Coalition, who have been spearheading demand creation drives across most of the South Central Africa, based in South Africa. So I want to take the pleasure, without any delay, to welcome Baptiste to make our first presentation. Then after her, we shall have Helen giving us a case presentation. Then after that, we shall have about some 20 minutes of reactions, and then we shall end with our announcements. So now I take the pleasure. I've already mentioned the house rules. If you are not speaking, please mute. If you have any reactions, you have any questions, you have anything you want to be helped with, just go to the chat box. There are people who are on standby to see whatever happens on the chat box, and then they will document whatever is happening and will react at the appropriate time. So I welcome all of us who are based from wherever, from South Africa, from Malawi, Zimbabwe, from Sierra Leone. I haven't seen. I don't know whether Sierra Leone group has joined already, but I know many other people are joining. Every minute there are additional, every few seconds more hubs are adding. So Baptiste, you're welcome. Now this is your time to take us.
Thank you very much. I'm just about to share my screen. And if you can see that, if you can give me a thumbs up so I know it's okay. Yeah?
Yeah.
All right. All right, so I'm going to share with you all some insights around demand creation. ITPC is the International Treatment Preparedness Coalition, as Charles explained, and my name is Solange Baptiste. I'm the Executive Director. We have titled this presentation, You Can't Demand What You Don't Know, and really looking at a model for community-driven demand creation for routine viral load testing. A little bit about ITPC. ITPC was birthed in South Africa in 2003 when there was really poor access to antiretroviral treatment because of the prohibitive price. At that point, it was about almost $10,000 per person per year to treat. Our mission, therefore, is to enable people in need to access optimal treatment. And by optimal, we are talking about affordable, available, and treatment for all that is safe. And we organize our work around three main areas, thinking about treat people right, so ensuring that people are treated with human rights and they're able to get optimal treatment, the right treatment. We're talking about making medicines affordable at ITPC to ensure that medicines are affordable to countries and to communities or recipients of care. And also from a community monitoring perspective, we look at watching what matters. So we continue to describe ourselves as the global community voice on treatment access. We're going straight into the problem. So what is the problem and why are we here? Why do we even have to talk about demand creation? And just wanted to put it out there because I'm not sure if the audience is all people related to labs or coming with a lab sort of lens or focus, but sometimes we don't often see the problem, and we have, in a sense, the supply, but do we have the demand side? So just taking a view at the latest global statistics, just making sure my thing is not in your way. Okay, the latest global statistics on viral suppression rates from the UNAIDS in its 2018 special analysis report. And you want to look here at people who know their status, people who are virally suppressed, people living with HIV that are on treatment, and then of course the gap to reach the 90-90-90 targets. And if we look at it here, we will see that in the red box, we have those, if you look at viral suppression, which is the gray bars, West and Central Africa, Middle East and North Africa, mainly Africa, have very low viral suppression rates compared to other countries or other regions across the world. I know Eastern Europe and Central Asia is also lagging behind, but given the focus of this discussion, I wanted to just highlight that the issue still remains. Why are we not achieving viral suppression? And then looking again at another data point from UNAIDS around countries that have achieved or near to achieving the 90-90 targets as defined by the percentages on the table, we will see, looking at the third 90, which is viral suppression, that we have a few African countries there. We have Botswana, Lesotho, Eswatini, Malawi, Namibia. And then looking at those that have achieved viral suppression among all people living with HIV, we still see Botswana there. And Helen will pick up on Botswana as a sort of a case study example in her talk. So we see that we do have this problem. So now what I'm going to give you are community perspectives from ITPC's work. We have community surveys, we have done rapid assessments, we've done work with PL/HIV leaders, we've conducted many workshops across the globe on routine viral load testing as well as differentiated service delivery. We're not only getting perspectives from Africa, but globally, and want to share the best practices across. We also have our baseline results from our viral load access from the Global Fund project we're doing in West Africa, preliminary findings in our global treatment survey, and of course our many years of experience across the world and working with community-based organizations. So some of the insights I'm taking you through come from 2015, but I'm going to take you all up to today. And these insights should be no surprise to you, right? We know that if there's a policy, it doesn't mean it's actually implemented. And at the time of this survey, 2/3 of the countries surveyed reported the existence of a government policy that mandates the routine viral testing to be part of treatment monitoring, but only 3 countries were reported at that time to have viral load testing happening. Someone's drawing on my slide, but I don't think that's me. Anyway, low healthcare provider initiative. This means that most of the viral load tests that are done are patient requested. So the patients are driving, not the healthcare providers were driving the viral load tests that were actually being done. In many cases, half of the countries surveyed said that the patients had to actually pay for the service, and patients also had to pay more expensive fees for genotypic testing if it was available. Sometimes it's very unclear how to get a test for viral load, the steps involved, what you need to do. It varied widely and was very unclear. And of course, the inconsistent result turnaround time, which I'm sure has been a conversation among this community here. How long does it take for one to get the results, and then what happens to the results, right? All countries reported stockouts of test kits and commodities related to viral load testing within the past 12 months, and also delays because of staff not being available. And then we also polled to see if any countries are using the electronic or mobile technologies to relay the readiness of results to participants, and only one country was doing that. Viral load availability is only part of the equation. It must be implemented, and implemented with treatment, education, and adherence support. Patients need to and have a right to understand what viral load tests mean. You can't just get your test back and it be a good or bad test. What's the number? What is the number? What does it mean in terms of adherence? Is my medicine working? Should I be switching? There's a whole component of support in terms of counseling, peer, community, or social counseling, in terms of support to have implications on adherence and ultimately resistance, which is an emerging problem. There's also confusion among healthcare workers and recipients of care about the use and the need for CD4 and viral load testing. There's reluctance on the part of many healthcare providers to actually switch based on the fact that maybe something is actually wrong with the person's adherence routine. And so there's some sort of provider resistance that is talked about when we speak with communities. Also, what is the meaning of detectable versus suppression? There's sometimes confusion among people living with HIV and recipients of care. What's the number to use? Is 200 the threshold? Is 1,000 the threshold? Is what WHO said is the threshold? What's the country doing? And then what's happening at the clinic? And then what I understand, all of that comes together in a very confusing way, especially in the context of U equals U, which is undetectable equals untransmittable. What are people supposed to be doing? Many times we have questions from community members that say things like, well, what's the number when I can't use a condom? So it's really an understanding of the whole context in terms of treatment, literacy, and education. So other last points on viral load testing here. Access is still largely concentrated in major urban areas, right? So we have long delays in the urban areas. And then even within the rural areas, we have the problems as well. Communities need more machines and non-urban centers, and we need faster access to innovation. We know about the dry blood spot tests, and countries still overpay for tests despite initiatives in place. Affordability is a whole other issue. Just some insights around the global global survey we're doing across the world. These sites here are the ones that are in progress, and the ones in the square boxes are the ones that are completed, because we've been delays on the ethics committees. But just to give you some preliminary insights in terms of timely first viral load after ART start, just looking here, this is timely first viral load following ART initiation is less than 6 months. So we have a whole bunch of people who are not actually getting a viral load test within a 6-month period, which is the time for you to be getting your next test. So people are unaware of the quality if their medicines are working, and at the time when they should be getting another test, they're now trying to get their test result. We're also seeing data coming up from our regional treatment observatory data on the turnaround time in West Africa. This is a regional project. So if you look across the countries on the x-axis, you'll see that there. There are few countries that actually get the number of people that are tested getting their viral load test results, the orange bar, within 2 weeks. We have continuous cases of stockouts, lab reagents. Helen will go further into this when she talks about country-specific examples. Low coverage of viral load machines, delayed results, average turnaround time for recipients of care to receive their results is 4.5 months from the time of the test. Our peers still do not understand the importance and benefit of the viral load test. So what it means for communities, and in an attempt to break it down, because sometimes we don't see it from the recipient of care perspective, the person who is living with HIV is standing in line for their tests. A viral load test, you need to understand it and you need to actually want it. You need to know where to access it. You need to then save money and get transportation to go get the test. You might need to take time off from work. You might need to save. You need to get to the facility. So even if you have the money, you actually have to get there. And then you need to get the test done. You need to save money to then go get the results. You may not always get the results when it is done. because the result may be thrown out, it may not be valid anymore. There are many reasons. You need to actually have the result in hand, and then the result must be used. And that's the part we often forget, that the result is actually for use at the ultimate end of the person living with HIV so that they can live healthy lives. So the circle here is where we have a lot of the breakdown with the labs, getting the result and actually using the result. And of course, the issues around getting to facility always bubble up. I believe I have about 2 to 5 minutes left. So the point I want to make here is that the bedrock of all demand creation is education. People have to understand what it is they're demanding for. If you don't know about it, you will never even be able to ask for it. And that will then lead to the advocacy agendas and targeting areas within and putting interventions out and ultimately leading to change. A couple of perspectives. We're thinking now that people are taking blood to make money, because I've had HIV for 18 years now and had my blood taken 3 times and never gotten a result for my viral load test. We have no clue what is going on. This is from someone in the Gambia. I don't know what you're talking about. Third line, the third line is the graveyard. So when you think about viral load tests and the ability to switch to second or third line. And then one more here, we should never reach the third 90 in the absence of the use of routine viral load tests. We will continue fighting HIV in the dark. People's blood samples are being taken, but people don't know what it's for. We travel from far, have to go get our blood drawn, go through the pain of a needle prick, only to have the blood sample discarded because the lab has run out of reagents. In my experience, those knowledgeable on HIV treatment are able to confidently interact with the healthcare workers, asking for things like viral load testing. What about those living in rural areas who aren't knowledgeable? Due to the lack of knowledge, they are not able to ask for these services. So in this light, ITPC has developed a demand creation model, starting with, well, where are we starting from? What's the level of knowledge? What do people need? That's the baseline survey. Developing a tool, it doesn't have to be a toolkit, but a tool that responds to those issues. And then through education, workshops, mobilization of communities, we bring them together, ensure that knowledge is built. And then within that, they're able to move to small grants, where I think normally the demand creation model usually breaks down. And what we found is the importance of actually sending money to the small organizations to be able to do advocacy. Even though advocacy is not expensive, it's not free. And then hopefully this leads to increased treatment access. I have 2 more slides and I will be done. How to create demand for routine viral load testing. So using the same model, we are explaining how ITPC has done it, and others have done it as well and have different models. We're just sharing our examples. So the baseline survey would come out with points like this. And then the toolkit that we have on our website here is the activist toolkit for routine viral load testing. And the key here is routine. It's not just viral load testing. And then the education mobilization. This is here an example of Be Healthy, Know Your Viral Load launch in Zambia, and then an N-line survey, which we're doing now, hopefully leading to increased access. So this is the model, which I just described, the baseline, the tool, the workshops, the small grants, and N-line evaluations, which has been taken up by the journal. And this is information about where you can get that. So this is my summary slide and conclusion. We have 463 days to go to achieve 90-90-90. We are far from there. Viral load testing is the gold standard for knowing if your treatment is working. So we've been talking a lot about coverage, and we're not talking so much about quality. And I think this is a good place to have that discussion, and the role of labs. Not ready to say less frequent viral load testing, especially in the context of U equals U and the neural tube defects that we've found. Governments using this as an excuse not to scale up routine viral load testing, as they are already struggling. We know the key and the importance of HIV treatment education and community mobilization. And success must be measured by getting to all who need it, right? Not just broad numbers, but what's happening in age bands, by populations, as we spoke about the issues in rural populations. Focus and investments must be on community system strengthening, not just on strengthening the health system. And then lastly, seeing recipients of care as part of the solution. So I'll pause right there and hand it over to Charles. That was my last slide. Thank you.
That gives us the context of our discussion this afternoon. It is a framing presentation. We are going to have another presentation from Helen, which is a case of where some intervention using the strategies outlined been implemented, and then we want to see what has happened, what have been the lessons. So Helen, you have the floor.
Okay, thank you very much, Dr. Kiaga. I'm just going to be sharing my my screen just shortly. All right. All right. I'm not sure if it's visible right now to everybody.
It on full screen, okay?
Good to go?
Yeah, that's fine.
Excellent. All right, thank you for the opportunity. As mentioned, I'm Helen Etya'ale. I'm the ITPC program coordinator. And my presentation is going to be building off of Solange's presentation to highlight a few examples of how ITPC has been able to support the process of demand creation around RVLT in country. So you've seen this model before. I'm just going to be focusing on the part in the box, which is how ITPC interacts predominantly with the countries. So in the first instance, it would involve a treatment education workshop, in this case around routine viral load testing, where participants will gain knowledge not only about routine viral load testing, what it is, why it's important, but they'll also have an opportunity to devise advocacy plans to address persistent gaps or issues in their respective contexts, so that once small grants dispersed, they're now able to implement those advocacy plans in country. So jumping right into the case study of Zambia, where we had a community partner, Etya'ale, that was one of the organizations that took part in an ITPC training and also received small grants to carry out advocacy activities for the implementation of routine viral load testing according to WHO guidelines in Zambia, with a focus on 3 particular districts that you see starred there on the map. Just a little bit about the context starting off. What was observed was that there was a widespread lack of knowledge of the WHO HIV treatment guidelines and the importance of routine viral load testing, both among people with HIV and also among healthcare workers. And there was also a general low coverage of viral load machines across the country. So then Etya'ale initiated this targeted interventions, which involved a mapping exercise to assess the availability of viral load testing machines across those 3 target districts, and also carried out treatment education workshops focusing on RVLT for people with HIV, healthcare workers, and community healthcare workers. And lastly, there were also policy engagement meetings, which served as a kind of platform for dialogue, bringing together communities, healthcare workers, and policymakers to address the existing low coverage of viral load testing across the country and what could be done. So this led to some positive outcomes that we can see, where community health workers and healthcare workers were sensitized about the importance of viral load testing. And RVLT was now integrated in these trainings, which community healthcare workers would do with recipients of care when they came to ART centers to inform them about why that's important. We also saw increased demand coming from people living with HIV themselves, now empowered with the knowledge and saying, "Oh, I would like to get a routine viral load test because I know how important that is to monitoring my treatment." So ultimately, the combined result of this advocacy and of this increased demand led to increased pressure at the provincial health office level, which ultimately led to the purchase of viral load machines at all the major provincial hospitals, not yet at the district level, but at least at the provincial hospitals. And from data emerging from earlier this year in one of the districts, we're able to see 85% of viral load suppression rates from the tests that have been carried out. However, there's still persisting challenges and issues that remain, which speak more to the systemic aspect of the challenges, which is that across the district, we saw there were instances where blood samples were being collected, but from the district health center and transported to the provincial health centers, but along the way, they were either getting lost, so recipients of care would never get the results, or they would reach the provincial health centers and there would be such a backlog that results would be delayed. Or in other circumstances where there would be a viral machine present, but it was not operational and there were no skilled lab technicians able to really address the issue. Or even the issue of transport, which came out also quite big as a major hindrance to the transport of samples from district to provincial health services for viral load testing. So although there was all the positive outcomes that we're able to see from the demand creation activities, there were still some of these persistent systemic challenges. And Zambia is not isolated in this case, as we can see from this data that's emerging from the Regional Community Treatment Observatory project in West Africa, is that oftentimes tests are carried out, recipients of care would not necessarily receive the results. And if we zoom in on Mali there, we see that Mali actually has the capacity to undertake 35,000 tests per year, but in 2017 was only able to carry out 1,455 tests. And this next graph, which pulls out from data emerging from one of the health centers in Bamako, the capital, gives us some clues as to what may be going on there, where we see over the last 3 quarters, there were either instances where there was stockouts of lab reagents for routine viral load testing, or there were lab equipment that were not functioning and therefore tests could not be carried out. However, it's not all bad, and we'd like to pull from another case study in Pakistan where we see successfully how both demand creation and the fact that some of these systemic issues could be addressed came together to lead to positive outcome. So a similar process was carried out there with the trainings and the small grants for advocacy. And once again, in terms of the issues that were being targeted, there was low knowledge about the need and the importance of viral load testing, and generally low coverage across the country, with only 4 functional viral load machines, and those were located predominantly in urban areas. And when we look at the interventions that took place, there were workshops, so demand creation workshops targeting community leaders and community support groups that were created, both to increase the knowledge within community, but also to equip with advocacy skills to now demand for access to routine viral load testing. And then other activities that were done with the trainings and the advocacy meetings with national and provincial AIDS control program implementers, UNAIDS, UNICEF, just to name a few, to kind of sensitize on the importance of viral load testing and the fact that there was still very much low coverage around the country. And so this led to positive outcomes, which we see where community leaders were sensitized on the importance of routine viral load testing and equipped with the skills to advocate. And also we saw increased demand now at the ART centers now, with communities themselves coming and demanding routine viral load testing, and also filing complaints through the APL HIV complaint management system. So all of this pressure, once again, just culminated ultimately to the formalized agreement between ART centers and the Aga Khan laboratories to provide viral load testing across the country. So now we've gone from having 4 sites where viral load testing can be carried out to 300 sites where that can be done. And from the tests that were emerging over the last year, we're getting viral load suppression rates of 82%. Putting everything all together from all these different case studies, we're seeing that communities have a role to play, and the case studies illustrate certain ways in which demand was achieved, increased demand was achieved. So through the increase of knowledge, through the workshops and demand creation workshops, through encouraging and empowering community-led advocacy to bring about the desired changes, and also through these community monitoring systems that allow, that help identify barriers to access, that help monitor stockouts, and help overall measure the quality of services. But what we also saw is that demand creation alone, I mean, it's important, but alone is not sufficient, because there's still in parallel those systemic issues that need to be addressed if access to routine viral load testing is going to be improved. And from some lessons learned from what we saw in Pakistan is the fact that the collaboration and involvement of all the relevant stakeholders from the very beginning of the process was able to lead to increased buy-in and also ultimately to successful increased coverage, which we saw in Pakistan. And Solange earlier mentioned about Botswana, which is one of the few African countries that now achieved rates of viral suppression under the 1990. And although we haven't done any direct work in this regard in Botswana, you know that ITPC is headquartered here. And Botswana offers a case study sort of how, a success model that can be brought about when we have both the increased demand, community demand that's there, and also addressing some of those systemic challenges. Where listed there really briefly is the fact that from the very beginning, there was a focus on routine viral load testing rather than just CD4 testing as the means to monitor treatment, pushing for a much lower threshold of 50 copies per ml as the measure for viral suppression, decentralizing the labs to increase access to viral load testing, and training, and in parallel training lab technicians, giving a sort of recipe of the ideal conditions to allow that to be feasible, as we saw in Pakistan. So in closing, I'll leave with this question, which is, how can communities be engaged to be part of the solution, to be involved beyond just the advocacy arm of things, but also being involved in actually addressing some of these systemic challenges that we mentioned earlier. And I think, as we saw in the case of ART delivery, where community ART groups being used for the delivery of treatments, then it's what it can be considered as well, where communities can be involved also in the routine viral load testing cascade to actually be involved in the collection or the transport of blood samples in the form of dry blood cells, of DBS in dry blood spots, excuse me, in order to be able to actually address some of those logistical challenges that we saw earlier, whether it be transport or delayed results or all that sort of thing. So just some points to consider. And I think with that, my time is up, and I will pass it back to Dr. Charles. Thank you very much.
Okay. Helen, thank you very much. And Baptiste, I think you have laid a good ground for the next few minutes of discussion. You've unraveled the ground on how to approach demand creation using a systems approach. There's no one magic bullet, though emphasis is being laid on the health, on the civil society, the patients who are always not seen as partners in this. We are trying to draw the attention to the fact that they can spearhead the drive to create demand. So I know there are lots of questions. I've been seeing the chat box very busy. So the people who have been monitoring the chat box, okay.
There are a few questions in the chat box.
Okay.
The first one is from Dr. Pasco, and it goes to Solange. The question is, among whom is the baseline survey being done? the baseline survey that was talked about, among whom is the baseline survey being done? Then the other question goes to Helen. How do you think these initiatives can be institutionalized and ensure long-term knowledge about viral load among the community and healthcare workers? That is the question to Helen. How do you think these initiatives can be institutionalized and ensure long-term knowledge about viral load testing among community and health workers? Then we have a question from Dr. Claudius, and is asking, is the demand creation toolkit available for use in other countries with acknowledgement? And if so, where can we access it? Yeah, those are the first 3 questions.
Okay. So please get to answer the questions, those first 3 questions.
Sure.
Baptiste?
Yeah, I can start, and then Helen, you can jump in. So I answered quite a few of them already on the chat. So just so that in case people are not reading always, I can just respond firstly to Pascal's question. In terms of this baseline survey, it's broadly, we do our baselines with among people living with HIV, leaders and recipients of care. In the case of the toolkit for viral load testing, it was done through this meeting that we had in Thailand, which was a 5-day intensive workshop on routine viral load testing and linking it to differentiated service delivery. And there were 30 activists across the 12 countries from 7 networks. They were also bringing perspectives from their networks about what the gaps, the issues were. And it is through that process and discussion that we set up the structure of what the tools should look like. And just to underscore that it's not always a toolkit. We've done this before where people felt that the advocacy tool that was necessary was a video that they can quickly show to their government officials for different issues. At one point it was around PMTCT at that time, and it was actually like a video about what that would look like. So in this case, it was a toolkit. And then I think the next question is Helen. Helen, if you want, I can also address some of it after you respond.
There is institutionalizing these interventions.
Yes. So
Helen?
I think, right. So thank you for the question. I think Solange already mentioned part of it in the terms that, in the fact that there are tools that are available to equip communities to have this knowledge. One of it is the RVLT toolkit, but also that the involvement in these workshops. So these are just a one-time event, but I think what we saw, at least in some of the situations, circumstances in Pakistan, is where there wasn't only, there were training of the community leaders, but then they were also able to train further the people living with HIV in structures, in very structured groups that were created to ensure that they're always up to date about the knowledge that is needed.
Just to add, Helen, can I?
Yes.
I think one of the key issues around demand creation is measuring it and linking it to the outcomes that we're looking for, right? So sometimes, especially in academics' brains, it's to move from, oh, people want this, to the actual viral suppression number for that country at national level percentages is a very big ocean. And how do you measure the correct things over a period of time to then link it and say this had some sort of association with reducing or getting to viral suppression? Because of course it's not the only ingredient in getting to viral suppression. And I think part of institutionalizing is getting governments to own this as part of their response in terms of the national plans, HIV plans, and being able to ensure that communities actually know what they're demanding in terms of quality. I think it's linking to a question someone else asked below. Being able to know that the knowledge is actually translating into demand, and how do you measure that, and then translating into impact. And that's the only way that governments are going to say, okay, this might be something we want to institutionalize or become more routine and actually own and take up. If they don't see the link, then it just becomes this one-off thing that projects get, money to do. And so that's really cool, but that's not going to be lasting. So we have work to do in terms of documenting to be able to make the case so that governments can take it on. And even that, the ultimate part of that is demand creation, because when we go and we disappear and this projects end and ITPC goes, you know what I mean? Then it's the people who are living in the countries who are recipients of care will continue to put that pressure. And so that's why the investment into communities and making the TALCs and the APL HIV organizations stronger and able to demand and hold governments accountable and labs and just generally the community accountable, it would be the way to go.
Okay. Yeah, I think you can again tell us what is appearing on the chat. If you have any intervention out there that is outside what has been presented, but is an experience from your country, you also would also want to learn from what you've done.
Yeah, Chair, there are about more 12 questions in the chat, but one participant called Aaron was putting up their hand. I think he wants to share something. Aaron.
Hi, good afternoon.
Okay.
Good afternoon.
I'm Aaron Shivemba. I'm Dr. Aaron Shivemba, the National Coordinator for Pathology and Lab Services at the Ministry of Health in Zambia. It's just an observation from Helen's presentation. Thank you very much for that elaborate presentation and on the SNAP survey that you did in Zambia. The points to note are that Zambia is a vast country. It's slightly more than 750,000 square kilometers with a population of 15 to 16 million people. So it's a very big and people are all over spaced. So what you could have found in these 3 districts would not be representative of the whole country. We have 114 districts in Zambia. And then we have 16 laboratories testing. So I don't know which period of time you did the survey, but we have 16 laboratories testing in all the 10 provinces of this country. And we have more than 30 viral load machines doing the tests. So I just wanted to clarify a point that what you might find in one district might not be representative of the whole country. Thank you very much.
Okay. Yeah. Thank you for that. Thank you very much for that comment. And I think, I'd just like to add precisely and specify that, yes, the work that was done was really focusing on those particular districts and was not used, it's not necessarily as a representation of the entire country, but it was just to illustrate the work that was really done in those target districts. And I think also the point was also just to show that while there were viral load machines that were available at the major hospitals, there were still some areas where access to viral load machines was still restrained, particularly in some of the rural areas, which goes to your point that there's still some areas where access is limited.
Okay, so can you read some questions quickly? We have about 7 minutes.
From Gesh, the question to both presenters. He says mostly emphasis is given on the availability and access of viral testing, delivery and communication of results to improve demand creation. Can you please underscore and explain a little bit more on the significance of viral testing results quality for demand creation? Yeah, he is asking about the significance of viral test results quality for demand creation. Then the other question is from Chris Chai Malawi. He says, does IPTC have tools to help improve viral load results utilization by clinicians? Are there tools to improve viral load results utilization by clinicians? Then the other question is from Dr. Pasco, and she's asking whether, in addition to quality, stigma is a big barrier to optimal viral load demand. Is addressing stigma part of the toolkit? Okay, she's asking whether stigma is also a barrier to optimal viral load test demand and whether addressing the stigma is part of the toolkit. Then the other question is from Naya, and it goes to Helen. Can you please explain community monitoring? Is this done from labs or patients? Yeah, she wants more clarification about community monitoring and whether it is done from labs or patients. And then the other one before I put a pause is from Fidelis, and is asking, how did the study evaluate impact of demand creation? Are there also issues with cost effectiveness of community involvement? What model is suggested for community involvement?
Okay,
I can quickly start. Yeah. The question around the importance or underscore the significance of the test result, viral load test result quality is definitely important and linked. We see it as inextricably linked to treatment education. So as somebody is demanding for viral load, they need to understand what it's going to be used for. And being able to understand what your test result is, the actual number in the context of your clinical status, and whether that number is good or bad, and what good and bad means, and then what are the next steps? What are the discussions one should have with one's clinician or doctor at that point? Is it around adherence? Is it around switching? Is it around your side effects? And how long do you then do your next test and come for follow-up? So it is a critical part of the chain for demand creation in terms of the quality of the test and then the use of the test results. ITPC focuses on communities of people living with HIV, so what we consider to be recipients of care, people standing in lines to be able to get tested, to try to receive their results. So we do not focus on tools and products for clinicians, as there are many organizations that already do that, but we work in conjunction with many of them. We work sometimes with MSF, we work sometimes, for example, on this one, integrating some of our work with IAPAC, which is working with the fast track cities, developing community engagement models with them as they also train healthcare providers. What was the next one? Maybe Helen, you can take it. The stigma.
Yeah, someone was asking whether stigma,
yes. Right, sorry, I'm reading too many things. Helen, jump in whenever you like, but stigma is not an explicit module in the viral load testing toolkit, but it is explicitly talked about and addressed in our advocacy for community treatment toolkit, because stigma is, of course, a huge barrier in terms of people's engagement with the health system, period, when it comes to HIV. And of course, viral load testing and checking the quality of your treatment that you're on is going to be affected by stigma. So we do not directly address it here in this toolkit, but it is definitely one of the things addressed. And there are other organizations that have strong tools on stigma, such as GNP+, who we work closely with for this kind of work. Helen, I don't know if you wanted to add anything.
Okay. Helen, do you want to answer? Do you want to respond to something?
There were some questions about the community monitoring, which I mentioned briefly just on that slide. Essentially, it's people live with HIV networks across the different countries, so 11 in West Africa, that are involved in the actual data collection. So there are data collectors that are themselves people with HIV who go to the various centers and are actually involved in the data collection process itself. And there are indicators that are spanning all across the treatment cascade, so whether it be prevention, also treatment, but also getting data about viral load testing availability. So there's data being collected all across those different indicators. And I think there was one question, I think also about cost effectiveness, where when we talked about the model earlier and talking about the small grants, the small grants are just I mean, they're being called small in the sense that it's just some funds being donated to the community to be able to enable these organizations to carry out advocacy activities in countries, but it's not that alone that was able to bring like the desired outcome. And as we saw in the case of Pakistan, for example, it was just part of the element. So really involved in that demand creation bit. But then on the other side, it really needed a buy-in on behalf of the government, the National AIDS Control Program, to really take that on board and using other funds to really now start to make viral load testing available for free. And make sure that this agreement that was formed with these labs was now put in place. So I just wanted to add that.
Okay.
Okay. Thank you. No, I think we shall end it at that. We may not be able to answer all the questions here, but the discussion should continue. The discussion does not end here. We have a number of platforms where we have discussions almost 24/7. On these platforms, you can just keep pushing questions or reactions or just giving solutions. We have the WhatsApp. Please use that WhatsApp. And the time is not enough for us to, to do justice to the subject and everybody share their experience. But we have this, extended time period where we can exhaust all that we want to say about a subject matter. So I encourage you to continue posting information on WhatsApp and continue the discussion. Also on Slack. Slack is a platform also where we are posting. You are going to find these materials that are being shared. We will post them on Slack. There are people who have been asking me, please register me on Slack. I registered so many people and the system blocked me out because the people I registered, a number of them did not accept my registration. So somehow the system can't allow me to register more people. But those of us who can register others, I think, can do so. But whoever is already registered there, please go and pick this information that is going to be posted. As I told you, this particular session has been recorded and it's going to be available on our website, on YouTube. We will share a link even on WhatsApp so that you can go back and visit and pick all this information, and all these presentations are going to be posted on the website. So the learning continues and the discussion should continue. This is South-to-South collaboration. Let us continue. Don't leave anything to yourself. If there's any intervention or any approach you have used and it has given you results, just post it on WhatsApp or wherever, and then members will react. And if you have a question, continue to do so. So I have a few announcements. I know all of us are aware. We are planning to have our first face-to-face meeting 1 year down the road since the program started. That was October 2017, and this will be October 2018, 1 year down the road. A lot has happened in the course of time, and a lot of exchange, new ideas and learning from each other, and peer influence has happened over the period. So we are going to have a chance to meet. We have been meeting on a platform like this one, but this time we are going to meet face to face. I can't wait to get that day coming. And it's just a few weeks, almost 2 weeks away. On the 15th to 17th of October, we shall all of us converge in Uganda. It's unfortunate that we couldn't pick everybody. I wish we could pick everybody and bring them down here. But we have asked countries to select 5 people whom the project, together with our stakeholders, are going to sponsor to come to Kampala. But should you have any other way that you could be sponsored, maybe through your implementing partner or through any other way, you could still have the chance to join the meeting. And if you need an invitation letter, if you need any help of any sort or any information, please, after the call, just shoot me a mail. Shoot me a mail and ask anything that you need. And if you want an invitation letter, we will quickly send it to you. But anyone outside the 5 official ones that have been selected, you are still welcome and it's open. You can join the discussion. It's going to be an exciting moment. All the stakeholders are going to be there, and everything around the viral load cascade, especially that has been challenging, will have to be broken down into biteable pieces for taking in, for all of us to know what to do to resolve issues around our viral load scale up and be able to meet the global targets. So the countries, you have been working with our logistics team. They are asking you to provide information, especially around what is needed for your bookings, your flight bookings, your hotel bookings. Please respond as quickly as possible to make it easy for the people organizing these logistics. There are a few countries where we haven't yet finalized the 5 people, and I call upon these ones to quickly help us finalize this. And I would mention these ones. That is DRC. DRC, we need to quickly finalize the 5 people that are coming. South Africa, I understand you have sent in a few, but the others you have not yet received. And then Southern Sudan. So the 3 of these countries that have not yet given us all the names, please do before the end of this week, so that by next week we finalize the logistics to see that we have a successful meeting. Otherwise, everything is being prepared to have a very exciting and educative moment while we converge together to discuss issues around our viral load implementation. I would want to see if Dr. Pasco has something to say. Dr. Pasco, do you want to have something to say in regard to October meeting? Okay, so it looks like Dr. Pasco is not there or is not getting me, but we are going to continue to reach out to you. We want to thank you for having filled the templates, the assessment tool, and it has been analyzed. We are going to be sending you some of the action plan templates, some materials for you to start preparing yourself. Some of you, we are going to get to you to tell you what you're going to do. Many of us have been selected to make a presentation or to share an experience and so on. So we will be sharing this in the course of the next few days. And if we ask you to send us anything, please do act quickly to help us with the preparations. Otherwise, if you have any questions regarding the meeting, you can still use the same platforms. You can still post your questions on WhatsApp. You can email me. If you need to ask anything or you need any help in regard to the October meeting. Nicholas, is there anything you want to say before I close down the meeting?
Not really. I think you've said everything.
Okay. Okay. So, and as I've told you, these materials are going to be made available. In the next few days, you're going to have the entire recording of this session. For the people who have not been able to attend the session, they will also be able to follow the discussion. The presentations that have been made are going to be posted on the website, on Slack, and a couple of other materials are already out there posted. So let the discussion not end. You know, the WhatsApp is open 24/7. Even if you wake up in the midnight, just post there a question. By morning, people will be waking up answering your questions. So the discussion never ends, the hope never ends, and we want to discuss how things are going to happen in the coming year. It's just exciting, and I want to thank you for the very vibrant discussion over this session, but also the vibrant discussion that goes on non-stop on WhatsApp and on Slack. Please, let's continue the discussion. This is the real community, and this is the reason why this community exists, that we may provide solutions by learning from each other. Thank you very much. Have a nice evening, a nice morning, a nice afternoon, depending on your time zone. Good. Have a good time.
Bye-bye, everybody.
Bye-bye. Yeah.